Welcome to the 905er podcast. My name is Roland Tanner.
I am Joel McLeod.
We've been wanting to record an episode on Ontario's healthcare crisis for a while. It seems that there's not a great controversy about the fact that there is a crisis after all, and a worsening one at that. Only really the most loyal of PC partisans and MPPs would really pretend otherwise. The stories of closed emergency rooms, hallway medicine, and massive staffing shortages seem like a daily occurrence in the news, to the extent that a state of perpetual public healthcare decline can seem like an inevitability. But if there's one thing that unites the vast majority of Canadians, it's a belief and support for our public healthcare system. We may disagree about the best way to make it work, but there is broad consensus among Canadians that they want a public healthcare system that does work. So why do we have governments who appear to be working in precisely the opposite direction? In the months ahead, we'll be looking at particular areas of the healthcare system in more detail, but today we thought we'd start with a 10,000 metre overview of the entire healthcare system with Natalie Mehra, Executive Director of the Ontario Healthcare Coalition, and ask her what created the current crisis in Ontario and where we should be looking for answers. Natalie Mehra has been Executive Director of the Ontario Health Coalition for more than 22 years. She has built the Health Coalition into the largest and broadest public interest group on healthcare in the province, representing more than 750,000 Ontarios in its network and more than 400 member organisations and more than 50 local chapters. During her tenure, the Ontario Health Coalition has won public interest amendments to every piece of healthcare legislation introduced in Ontario in the last 22 years. That sounds like a good place to start.
You looking to make the most out of this life and optimize your personal wellness? Then check out the Natural Man podcast. Join me, host Mike C., as we explore all areas of human wellness, physical, mental, and emotional. Learn strategies to optimize your own well-being and be in the driver's seat of your own health. Remember, your doctor works for you. Learn biohacks, neurohacks, ways to improve sleep, and ways to optimize your body and your mind. Check us out on Apple, Spotify, the Fountain app, and at naturalmanpodcast.com.
Welcome, Natalie Mehra, to the 905er podcast. You're the Executive Director of the Ontario Health Coalition. Thanks for joining us so much today.
Thanks for having me.
So it's what we're going to be speaking about today is kind of an unwieldy and huge subject, which is the crisis in healthcare, which I think, or certainly most listeners to our podcast, I think will probably agree that there is a crisis. But it's almost a matter now, like, where do you start in terms of where the different elements of the crisis kind of lay and what needs to be addressed first. But perhaps you could kick off just by giving us your take on the current state of healthcare in Ontario and what's going on.
Well, end to end, really, we have the health system is in crisis. We've never seen anything like this. And it's because there really is no care without staff. And there's a staffing crisis, the like of which we've never seen. Shortages in every sector. Hospitals have the most dire staffing shortage ever in history. 158 emergency departments have 158 emergency department closures have happened across Ontario over the last year. That has never happened. 3 would be shocking. 158 has never, ever happened in the whole history of Ontario. So that puts it in context. In long-term care, same thing, critical staffing shortages to the point that care that is needed by these frail, elderly, often residents just can't be provided. Home care in such critical, so that's home visiting nurses and PSWs, such critical staffing shortages that the people being referred from hospitals for home care, up to 50% of them in some regions cannot, they are not taking the referrals even. They can't provide the services. Really the worst staffing shortages we've ever seen. And that means basic care can't be provided to Ontarians. Something has to happen, and really nothing is happening to resolve it.
Now, this staffing shortage, I mean, we've all heard stories about the burnout for nurses and doctors and long-term care support workers due to COVID, that the pandemic, just the long hours, the stress, the risk to life has just burnt out the workers. Is that in fact the case, or is there maybe a little bit more to the staffing shortage that we're seeing?
Well, see, Ontario has had, prior to the pandemic, we had under the Liberal government, well, so it really goes back to the Harris government of the 1990s, massive, massive, massive hospital cuts. About 18,900 hospital beds were cut in Ontario. Half of the chronic care bed capacity, what's now called complex continuing care, but those are the longer term beds for mostly seniors and people with chronic illness and so on. Literally half of them were cut, and a third of the acute care beds were cut. And then that total of hospital beds was kept low. I mean, little bits of opening up here and there, but never, those cuts were never reversed. And as the population has expanded and aged, that has never been reversed. So Ontario, and then the Liberal government, came in. And after the first few years, sort of around 2006, they engaged in a decade of austerity cuts to the public sector. So, holding hospital budgets at 0% increases year after year after year, and so on. And so that was to force them to downsize their services, to privatize and downsize their services. And then they opened it up starting in 2016, started to refund and so on. And then the Ford government came in and brought back in real dollar cuts in. So that's, keeping funding at less than the rate of inflation, let alone population growth or aging. In 2018, when they took power, we entered the pandemic with the fewest number of hospital beds of any province in Canada. I mean, the fewest by a long shot. We're 14,000 hospital beds below the average per capita number of hospital beds of the other provinces. And among the entire OECD, so every sort of nation with a developed economy, we are third from the bottom. Only Chile and Mexico have fewer hospital beds per person than we do. And of course, the crisis that we have seen in our hospitals was terrible before the pandemic. People waiting on stretchers in hallways, in sunrooms, in every possible space they could put them. And what that means is there's no staffing for those patients. There's, the nurses then have to stretch themselves to cover more patients without the funding and so on. And that's the hospitals, but you could replicate that across long-term care and home care. I mean, that's what's happened. Ontario funds healthcare at among the lowest rates of all the provinces. We're like third from the bottom, second from the bottom, etc. We fund our hospitals at dead last in the country. And all of that has been about downsizing and trying to privatize healthcare. And so then the pandemic hit, we had no surge capacity, zero. And we had this unprecedented international crisis. And so the existing staff they've lost their vacations, they've been redeployed, they're doing ICU work and things like that they've never done before. They're traumatized by all the death and loss in long-term care and in hospitals. And those that could retire have retired. They have left. People have gone for early retirement. They've left for other sectors in the thousands. And this is how we got to where we're at.
You mentioned how the drive that everyone's talking about nowadays is the drive towards privatization. We're hearing that the current Ford government is talking about providing more surgeries in private clinics that apparently will be paid through OHIP dollars. But the question I have is just, it's like a shuffling of resources. Maybe you can explain to me the rationale behind it, but if we're still paying OHIP dollars to a private clinic to provide knee and hip and joint surgery or cataract surgery, that kind of stuff, why does the private sector provide a better or a solution to this if it's still coming out of public funds? I'm not quite getting
the
that.
private sector absolutely doesn't provide a solution to this. In fact, every hospital in Ontario has operating rooms that are closed for weeks or months at a time, or even permanently due to underfunding. Mm-hmm. The facilities exist. There's no reason for us to pay now to recreate them, only owned by private for-profit entities. And virtually every large hospital will have one, maybe two ORs operating on the weekends for emergencies. They run their ORs from 8 a.m. to 4 p.m. They're closed in the evenings and on weekends because they would need the funding and the staffing to run them, right? Mm-hmm. So private clinics don't create new staff. They don't create new funding. They take funding away. They take the existing staff away from the local public hospitals to serve the private clinics. There's no solution there whatsoever. There's one workforce. A nurse is a nurse is a nurse, if she's working in a public hospital or she's working in a private for-profit clinic. The difference is that the private clinics only take the profitable surgeries. They only take the well patients, the people who can walk in and walk out for a 7-minute cataract surgery. They want high volumes. They want easy patients. They're not going to take people who are attached to all kinds of tubes, or people who are obese, have diabetes and COPD and heart arrhythmias, who might code on the operating room table. They take the profitable surgeries and the staff and the funding out of the public hospitals. That would be damaging at any point in time in this province, in this country, and anywhere else. But at this point, when we have the most profound staffing shortages we've ever seen, it will be devastating. It will be devastating. It will mean that those people waiting for cancer surgeries, the more complex surgeries, people who have comorbidities, have dementia and need surgery, who the private clinics are not going to serve, they're not profitable, will be left with a public system with much less staff and money to provide for them. And at the same time, the for-profit clinics actually do charge patients. They actually do illegally, charge patients for a whole array of things, and they sell add-ons, and it's like snake oil salesmanship. They tell people you need an extra eye measurement test for your cataract surgery. It's $200 a person. Well, those are completely unneeded tests. The OHIP covered test shows the same efficacy. There's no added value for doing that. But if you have 1,000 patients and you charge them all $200, that's $200,000 extra dollars of income a year. In addition, they're charging people outright for the surgeries and the diagnostic tests. Illegal in Canada. The Canada Health Act says all medically necessary hospital and physician services. That means your surgeries, your diagnostic tests are covered. That's what we won when we won public Medicare in this country. And yet we've phoned every private clinic in the country multiple times. We've posed as patients. We've said, we want to get a cataract surgery, we want to get a shoulder surgery. And we've caught the majority of them, not some small portion, the majority of them charging patients for the surgeries. Outrageous prices, like 4, 5, 10 times the OHIP costs for those surgeries, out of pocket, mostly to elderly people who need those surgeries, who then have to scramble to try and find the thousands of dollars to pay for them. It's outrageous. So not only do they not solve the problem, they bring a whole host of new problems.
So a couple of things coming out of that, I guess. I mean, if private surgeries are acting illegally, I guess, you can highlight things, but one of the most frustrating aspects of all this is that although there seems to be a widely acknowledged crisis in healthcare and pressure to kind of move towards the private sector, the kind of level of public outrage at this isn't matching it isn't what I feel it should be. I mean, if people are acting illegally, how is that allowable? Why is no one going in and suing these people, or calling the police on them? It seems to be a disconnect between facts that are uncontroversial about the current state of healthcare and the level of kind of public outrage at it. Why do you feel that is?
I think there's two things at work. One is that for almost an entire generation, we have been trained into expecting diminishing services. Canadians have been told repeatedly that healthcare is eating up the provincial budget and things, even when healthcare is declining as a proportion of the provincial budget, or, in Ontario, that hospitals are too expensive, even when we fund them at the lowest rate in Canada and have the fewest beds left of any industrialized country. I mean, it's just a propaganda campaign that is about winning tax cuts for the wealthy and for corporations and cutting public services to provide a market for privatization. I know that sounds conspiratorial, but I mean, we've watched it unfold before our very eyes, and that's what's happened. Right now, around the Ford government's plan to now privatize the core services of public hospitals, really sort of, if you think about it, the Mike Harris government of the 1990s, the conservative government in the 1990s, and I say this in a nonpartisan way. I mean, we just tell the truth and people vote how you want. But they privatized home care, and it's been a disaster ever since. They handed over the majority of long-term care to for-profit companies, and we all saw what happened with that in the pandemic. It's been a horror show. And now the Ford government is coming to privatize the hospitals. That's what's happening. For us at the Ontario Health Coalition, we're getting volunteers in droves. I mean, people are upset about it. We're hearing from it. I was at a public meeting in Chesley, Ontario, 400 or 500 people out in this very small town in the west of Ontario towards Lake Huron. And as soon as anyone mentioned fighting the privatization of the hospitals, the entire audience erupted into applause. These are conservative communities. They don't want their hospitals privatized, but people don't know how to fight back. They don't have a way yet. So we're working to provide a way. We're going to actually hold a citizen-run referendum to get people to vote against it en masse across Ontario, but they need a way to kind of fight back. And they also just need to know that their expectations that their hospital services would be there and that they're not too expensive. Of course, we can afford them. Richest country, one of the richest countries on earth at one of the wealthiest times in our entire history, we can afford these things. And anyone who claims otherwise is really saying it because they want to see them downsized and privatized.
It's certainly a narrative that we just heard since the 1980s. I feel that for some reason we can't afford what our parents could afford.
Yes.
So universal healthcare that our parents paid for, and sure, science has developed and there's new treatments now that didn't exist in the 1950s. I get that, but we can afford to have 3 cars per family, or we can afford to pay the gas to drive 50 miles a day to work, but our society can't afford to provide a basic level of decent healthcare to people who need it. It's infuriating. And actually, I just wanted to, you spoke already, about the shortage of staff, and I wanted to address, just because it's something I've had some personal kind of experience of recently. It used to be that we knew there were GP shortages in rural areas, and certainly I've been seeing this year that we're starting to face GP shortages in the 905 region, in the region that we cover, and personal experience in Burlington of this, of a surgery where a doctor basically retired. They're not able to, that particular surgery isn't able to replace him, so they basically had to fire or release a whole bunch of patients. Some of those patients are very, very, people who need a lot of healthcare, and they're basically finding the situation of, they go to a surgery and say, like, I'm looking for a doctor, and when the potential new surgery finds out that person's medical history, they say things like, well, we're not really qualified to handle your case, which makes no sense to me, because a general practitioner is a general practitioner. But people are being denied GP access. People in deep and severe need of healthcare, of access to a GP, being denied it on the basis that they're too sick. Is this something that you're familiar with, or you've come across at all?
Yeah, yes, I have. And actually, there is a sort of rule in the College of Physicians and Surgeons that physicians are not allowed to kind of cherry pick their patients that way. But of course, I mean, what's a patient going to do? Make a complaint and force a doctor to take them? How, for good reason, they're going to be reticent to do that or reluctant to do that. And it's a problem. I think more the problem is just that so many people have retired coming out, as we're in the pandemic continues, and we have a shortage. There are all kinds of nurse practitioners in Ontario who are trying to practice, who could practice in clinics and community health centers or nurse-led clinics of their own and do that kind of medicine. It's called primary care, kind of the front door of medicine, can be provided by a family doctor or nurse practitioner. And the province is not providing them a way to be able to bill OHIP or have salaries to be able to do that. So instead, they're setting up private clinics. One solution would be for the province to actually allow the nurse practitioners salaries, hopefully salaries and not fee for service, but to actually provide those services. And then the other is to expand the community health centers, because that helps to bring physicians and the team of practitioners together, so that you can have social workers do the social work part and physiotherapists do that part and doctors do the doctoring.
Actually, funny enough, it was one of those surgeries that this problem arose from. But that's by the way, because I'm a huge fan of that model, and it's a model that I've actually benefited from myself. I was familiar with it in Britain, rather than the kind of independent GP.
Yes.
But, and yeah, I mean, an absolute, in terms of things like providing for more mental health support, that model was fantastic, because it means you can, like you said, you can have a social worker on staff and provide services that otherwise aren't available in the community. But they're also faced with a dilemma of as I understand it, actually, that if you're a GP and you're looking for a job, and you can go to a family health team, or you can set up on your own. Under a family health team, you end up earning less, because from your budget comes all these costs that you're supporting social workers or dietitians, all these other great things. So you're actually going to earn less as a GP through that model. Is that, I've heard that suggested? Is that true?
I'm not sure if that's true or not. See, there are different models. Community health centers are actually local agencies. They're not for profit. They have elected community boards, and the physicians are on salary.
That's different.
And
from
then they work in the full team, like a much broader team than the family health teams.
Okay.
The family health teams are groups of physicians. They may have they'll have some other types of health professionals, but not the full range of them. Okay. And it's kind of a group practice. And then how they fund their group practice, is partly decided by the doctors and partly decided by the funding formula. And there's kind of an array of funding formulas from the province. So I think the real issue is we have a shortage of physicians to some extent. And we have sort of patterned the number of physicians on a kind of old-fashioned idea of physicians. Physicians work different hours than, their grandfathers would have, and so on. And so that's part of the issue. And so we just have a shortage all around. But we do have these people who are not practicing to their full potential, who exist. They're out there. They could do it, but they have no way of doing it. And I think that, we should demand of the Ford government, how is it possible that you have all kinds of people who can't access primary care? They can't get a family doc, and you won't allow the nurse practitioners a way to practice and provide that care for them? That's ludicrous.
So I guess the question that, all of our listeners who are listening to this episode right now are wondering, well, how do we fix this? And it sounds to me that what we have and the public sector side of things is kind of this patchwork quilted model of service of family health teams, community care centers, and specialty doctors all getting paid in a different formula, which some are more appealing than others, some are less. So the question, I guess, is how do we fix this? How do is the public sector so broken that we need to scrap it and come up with something new, or is it a matter of readjusting resources? People want to know, how can we fix this system so that the health the health treatment that we need when we need it is available, and that we are paying out of pocket.
Yeah, well, we've covered kind of a lot of territory. So I think since we're focused mostly on what's called primary care, like family doctors and nurse practitioners and so on, and hospital care, I'll stick with those in answering. I mean, the responsibility for planning and delivering healthcare is the responsibility of the provincial government. There used to be an agency called Health Force Ontario, which was an agency of the Ministry of Health that was responsible for health human resources. When the Ford government came in, they rolled that into their new super agency, and it no longer exists. But it's their job to do this. Given that it takes a long time to train family physicians, we need to increase the number of family physicians, and it takes a long time to train them. So in the interim, we need to create teams that can provide that service all put together, right? They can make the family docs that we have sort of stretch out by having the physio part of it done by a physio, having the nurse practitioners work to their full potential and so on, so that people can get access to that. That would take a government that is actually, concerned about and dedicated to planning to provide the healthcare that people need. And we're going to have to force the Ford government to do that, because they are not. They are interested in cutting the public service and privatizing it. That's what they're doing. There is no private option for family docs. At the moment, we have these virtual clinics where they're charging people for access to doctors illegally. Again, you cannot charge in Canada for access to a doctor. If your listeners are paying, they should be making complaints to the College of Physicians. They're not allowed to do that, or make complaints to us, because we're going to levy a major complaint to the federal government. Nobody should be paying out of pocket for access to doctors, but that they're allowing, Maple, which is a for-profit, and these other companies to do this online, and they're growing the market for them by not providing the access in the public system. And so we're certainly not going to complain about a patient accessing where they can, but the solution is to provide access in the public system. And that means building those clinics, team-based clinics, and supporting the nurse practitioners, and expanding the number of family doctors. And in the hospitals, I mean, if they just ran the existing operating rooms for, 2 to 4 hours more per day, it would be a matter of months and all the backlogs would be cleared. They need to get the staff back. Well, the government has put a wage cap on the nurses and the health professionals, and they lost in court. The court ruled that wage cap was unconstitutional. So, I mean, these are the people who've literally risked their lives through the whole pandemic. It's just a slap in the face to them. They need to stop fighting to keep the wage cap on.
Yeah,
that's
and
ludicrous.
again,
I mean, that's minimum.
It's like, I can't believe there is a lot of outrage about that.
Yeah, it's just ridiculous.
And this is, for listeners, this is a recognized model of the provincial government. They did it to the teachers too. That you do something illegal, and then you spend a decade working out in the courts, and then
and we're paying for these court challenges with our money that should be going to ameliorating healthcare. It's just ludicrous. So there's an array of things they could do to bring staff in to deal with the staffing shortages, and they should be doing those things. And we wouldn't need, we never need for-profit clinics. We have hundreds of public hospitals across Ontario that are underused.
I just have one follow-up question I want to ask, and I'm going to play devil's advocate here. In any model, is there a place for a private sector component to the healthcare system? Because we hear that we did have some private sector influence or not influence, but just components of it prior to the Ford government. So it's not completely new to us. But I'm wondering, what is that something that we should be considering, just in terms of expediency and in terms of effectiveness to people? I just put it back to you to see if that's a possibility.
Yeah. Well, I mean, we're certainly not talking about publicizing every single health service. But I mean, the systems that provide care that are for the elderly, for the sick, for the dying, are supposed to be based on providing care that people need. When you introduce the idea that you're trying to make money off of people in that situation. What you're talking about is taking money out rather than putting care in. It doesn't make a lot of sense. You're always in a kind of conflict of interest there. Home care that is run for profit has taken the money out of the staffing for home care. I mean, the vast home care is provided by nurses and PSWs and health professionals. Long-term care has taken their profit out of the staffing that provides care. For-profit hospitals and clinics take the money out of extra billing patients who need services and out of replacing better trained staff with lesser trained staff. That's what they do. And so, no, it's not in the public interest to do those things. Should we publicize every pharmacy in the province? Well, no one's saying that. You know, should we take all doctors and put them on salary? Well, you know, that would not be possible, and no one's really calling for that. You know, what we're calling for is a growth in the parts of medicine that work the best, like team-based approaches. And yes, community governance and community control over them, which means public control, is better. There's no question. But you know, I think sometimes and I'm glad you asked the question because it gives a chance to answer. Sometimes the advocates for privatization try to paint the people who are advocating not to lose the public healthcare services that we have right now as if there's some kind of drive that is anything other than practical and pragmatic and in the public interest. And that's really not what it's about. It's based on seeing what happens in the United States and where they've introduced privatization in Canada, and responding to it. Governance that is in the public interest without taking profit out at the expense of patients is better. And that's what we should do.
I could speak also that, you know, in the UK, that although the UK NHS in some ways is much more comprehensive than the Canadian healthcare system, there also is a parallel private healthcare sort of available to people, which was, you know, not helpful, let's put it that way, because the people who are making decisions about the NHS generally don't use it because they're wealthy politicians. But the other thing was the private public partnerships was something that the Labour Party in Britain under Tony Blair was very keen on, and were just a complete disaster.
Total disaster.
I mean, just a fast like catalogue of disasters of, you know, and it's like, well, if ultimately you pay the same amount for the same treatment anywhere in the world. I mean, ultimately it costs so much to use a stupid example, it costs so much for a bandage wherever you are. If you then say, well, we're going to give 25% or 50% of the cost of that bandage to a for-profit company, well, obviously that bandage is now going to cost 50% more. It's like the math is not complicated.
Well, it's one of those things that we saw during the COVID pandemic here. For years, the long-term care homes were being stripped of resources and staffing, and staff were paid as bare bones as possible. And we saw what the consequences of that were. I always looked as human beings are poor investments. Like, if you're looking for a business model, we're a very poor investment, especially as we get older, because we just require so much more specialized, costly treatments. Like, just if you want to maintain, I'm not even talking about care, just, you know, cures for disease. I'm just talking like a quality of life care, you know, just the surgeries and the apparatus that are sometimes required for people just to live. We're costly investments, and I don't understand how you can make a profit in there unless you're going to charge a lot and offer the bare minimum possible.
Exactly. Like in long-term care, as you're saying, 70% of healthcare costs are labor. Care, the conditions of work are the conditions of care. That is the bottom line. And so when they look to make room for their 15% profit or whatever it is, look at long-term care. The for-profit homes have a more precarious workforce, so more part-time casual staff. They have significantly lower wages. They had much worse staffing shortages, much higher death rates in the pandemic, and much poorer outcomes long before the pandemic. I mean, all the way through, much poorer outcomes because they take their profit out of the staffing. That's the bottom line, and out of the care. And I think as Canadians, like, central to our belief system, fundamental to us, it's what makes us different than the United States, is the idea that we take care of each other, that care is based on our medical need and not how rich we are, and that care is provided in the public interest. And as we turn these services over to private for-profit companies, like if we allow the Ford government to turn our public hospital services over to private for-profit companies, we will not be able to protect those fundamental values of equity and compassion that are the thing that I think we're all so deeply proud of as a country. And it just won't be possible. And can we go back? Well, we tried to roll the long-term care industry back to public after the military exposed cockroaches and people dying of dehydration and starvation in 2020 in Ontario, Canada, and the government, actually, the Ford government, is giving the majority of 46,000 new beds, 30-year licenses for them, to the for-profits. And in fact, the chain company that has won the most of them has the highest death rates in the pandemic. How could that be? I mean, it's so hard once they're in to get them out again that we just can't let it happen. We can't. It's fundamental to who we are as a people, I think.
Yeah. I once again, the level of outrage that we should have. I mean, it's almost impossible to maintain the level of outrage necessary when you hear that. And again, I'm just going to throw in an anecdote of my own, just for the hell of it. And it's not Canada; it's from another. It's from Britain, but just my own family experience of for-profit versus non-profit. Actually, both outside the NHS, but a for-profit long-term care home versus a non-profit long-term care home. And shopping around for a place for my mother to go, the worst place I saw, which was literally like a nightmare come to life. And if you ever visit long-term care, always go without making an appointment so that they don't know you're coming. That's a hint for people ever going into that. So we did that. This place was like something from a movie of hell on earth. It was just horrendous. It was privately owned. There were Alzheimer's patients just lying in their own urine and goodness knows what else, literally crying out, ignored by the staff. It was also the most expensive place of all the long-term care places in that region. And the non-profit place that we actually went to was absolutely stellar, absolutely fantastic. Could not praise them enough. Was actually coincidentally designed in a way that completely controlled and minimized the spread of COVID and other diseases. And it was like night and day. And it's like this, it was like you couldn't hope for a better example of the contrast between the for-profit mentality and the non-profit or public mentality. Just unbelievable. But it doesn't seem like there's I mean, obviously we're trying to raise the kind of awareness of this on our podcast, and I think we need to come back. We're just scraping the surface really today. I feel I'd love to come back and do an episode on those illegal charges. Just so that alone would be speaking about so many other things.
I'm happy to. I do think people are upset, and I do think they care. I think the issue is people don't know how to make a change. We have to, I think, provide ways, as our job as the Ontario Health Coalition is to try and provide ways that people can affect these policy decisions that affect all of our lives. I mean, our best plan, we figure, there's been no democracy. People have never had a say in any of this. People would never vote to privatize healthcare. It just would never happen. And so we have to try and force democracy into it. And that's what we're trying to do. So we're going to try and hold this massive vote. We're going to try and get 1 million votes across Ontario. People are asked whether or not they want to see the hospitals privatized. That would shake any government if we succeed in doing that. So we'll try that. But I mean, definitely, I think people need a way to raise their voices so that it matters. And any of your listeners, I mean, the one thing you can do is just email your MPP You can go to the Legislative Assembly of Ontario website, and you can, there's a list of members, that's MPPs, members of the Legislative Assembly of Ontario. And you can find your MPP and email them and tell them, you don't want, I mean, if they hear from everyone en masse, it feels like a little thing, but it starts to shake them, it starts to make them think, oh, we better slow down,
Oh, yeah. Contacting your MP definitely works.
Oh, yes.
It's one of the things, Joel and I both have some experience of being on the receiving end of those letters, and it works. Do it.
Yeah, there's something that drives fear into an office worker's heart than all of a sudden seeing a flood of emails coming into their inbox, all saying the same thing. It's it does work, people, believe it or not. But I do see that our time is coming up, so I'm going to say we might have to cut this episode. Just end it where it ends. But thanks very much, Natalie, for coming out. We definitely want to have you back on to follow up on that campaign and the and everything else that you're doing there, just to because I don't think this story is going away anytime soon.
Well, thanks very much for having me, and thanks for covering such important topics for people.
Thank you.
Appreciate it. Thanks.
That's it for this episode of the 905er. Thank you for listening. As always, you can send us your feedback, thoughts, and concerns or ideas for future episodes to our email, info@905er.ca. We'd love to hear from you. You can help us keep the 905er going by financially supporting us through Patreon as well as PayPal. Visit us at 905er.ca and click on the support tab. As well, links are in the show notes for your convenience. Lastly, you can find us on social media. Search for _905er on Facebook, Twitter, Instagram, and LinkedIn. So long for now. See you next time.